Good evening, my name is Dr. David Highmarsh of GP Templates, and in this video we're going to look at the types of study and what we can draw out from them. So first and foremost, you'll all be aware that there are multiple types of study and data that's out there. And going from top to bottom, we've got systematic reviews and meta-analyses, randomised controlled trials, cohort studies, case control studies, case series and case studies, and finally expert opinions and editorials. What we're going to do in this video is go through each of these turn by turn and draw specific formulae that we need to be aware of them, and we'll go into some calculations for it. So from the bottom, expert opinion and editorials. So generally an expert in the field will propose their opinion based on their clinical experience and acumen through years gone by being in medical practice. I would argue, though, that don't write this off, because actually they could be right, and just think about why they haven't had time to look into it or to study it. Maybe they've not had the money to look into it. And also, general practitioners, say compared to our secondary care colleagues, don't generally push out as many publications, so maybe they're not driven to actually write up their findings and push it out. So a case series is a lower form of evidence, and it generally takes a number of case samples and puts them together in one paper. The positives of this is that it's relatively quick and simple to do, and it's good for studying rare events and rare diseases. There's no need for control groups because you're just presenting a series of patients. Negatives from this, obviously it's got limited in scope and also generability, and there's inherited bias in terms of the selection that you're going for. And so it's very difficult to draw multiple conclusions, and so normally you try and refine a specific question for it. Interestingly enough, I have a case review published. So this was an interesting case. So this is a lady who presented when I was on my obstetrics rotation during my ST1 year, and she had exercise-induced anaphylaxis. So she was a young lady at 23 who the concern was, as she entered normal labour, that she would have a reaction to it in terms of anaphylaxis. So it was a very dull night shift. I then managed to find a case series where people had dealt with this before, and they advised that she had a series of hydrocortisone either intravenously with an anaphylaxis box at hand. So I used a case series to then influence this case report. The theory being that hopefully this case that I've presented, as it's now in mainstream publication, could then be used for a further case series. So moving up the ladder, we've got case control studies. So this compares people with condition to those without it. Okay, so it's retrospective, so you're looking backwards. Advantages of this: it's cheaper than randomized controlled trials. You can use small teams, and it's very useful in rare diseases. And it's useful actually just to get a starter for 10 and seeing how things are going on. Disadvantages: obviously you've got massive amounts of confounding factors, because you've got so much recall bias there as well, that you just need to be make sure that the interview questions and the interviewees aren't leading the patients, and that obviously you're not having your own bias draw into on this. And unfortunately, causation is unlikely to be proven from this, and the control groups, again, trying to get someone who's matched to the actual personnel with the disease is very difficult to get. Following a case control study, you will form an odds ratio. Okay, so this is the ratio of those who have got the disease, not got the disease, and who have been exposed to something. Okay, so you could look at people who've been exposed to a specific event, whether it be, say, nuclear disaster, who are living in a certain area, subsequently developing cancer. And you take the ratio of those disease present and disease absent. Okay, but due to maths, you can sort of cross multiply them of those ones, and I've got that demonstrated down below. With the odds ratio, a ratio of 1 means that there is no association between the exposure and the outcome, and less than 1 that is protective, and so likewise the other way. So let's take an example. A study looks at smoking and heart disease. The odds ratio comes out as 3. Now, you can interpret this in 2 ways. Either the odds ratio of someone with heart disease being a smoker is 3 times as high as those without heart disease, or the odds of someone who smokes as having heart disease is 3 times greater than those who don't smoke. Okay, so again, we are unable to draw causation from this because of this study. Okay, so just put it into perspective. If it's less than 1, think about protective factors, so exercising, smoking cessation, new drugs that you're trialling, and food groups. And likewise, if it's increasing risk, think nuclear waste explosion, smoking, new drugs, again, who they're actually causing harm, and food groups. So the lovely one that they push out is, red meat that seems to always be in the press. So example, let's say that there was a fictional company called Chernobyl Wonder Meat Sausages, and they showed and there was concern that there was an increase in bowel cancer. A case control study was conducted to try and work out the odds. Okay, so they've got those who've eaten the sausages and those who've not, and those with bowel cancer and those who haven't. Okay, and you can see I've done all the calculations there. Now the results come out at 0.2. So that's 0.2 or 20%. So what do we actually say about this? Now, as we go back to our original example, as it's less than 1, it's actually protective, okay, from this. So it's not giving us the example that we were expecting, because we would expect that given nuclear fallout, that there'll be a high amount of radiation in the sausage, and the theory being that it's being hyped up is that there'll be an increased risk of cancer. Again, this is all made up. This is just to illustrate this odds ratio example. But it hammers home the point that correlation does not equal causation. Okay, so just be very, very careful with any presumptions that you're making. So moving onwards. Cohort study takes a series of people exposed to a certain event and watches them over time. It's normally longitudinal and taking a very, very long time. It's a high risk of confounding factors as no one is put into different groups or randomised. They are literally just, will you sign up to the study and we'll see how you get on. So a good example of this is the Framingham Heart Study. Advantage of this, it's cheap. Cheaper than an RCT. It can start to study causal relationship as well, and it can start to identify rare risk factors, especially if you've got a large cohort of people. You can start to measure incidence from it, okay, and you will pull out multiple outcomes, okay. So think about, you want to measure, say, prevalence of heart disease, hypertension, diabetes, and even death in a group. You can cover all of that in one, and because you're keeping the same group over time, you're reducing suspicious bias. Okay, disadvantages, it's not randomised or blinded, so it needs a massive cohort to make sure that you're not adjusting your power. Causality will likely require further studies, okay, and it's not useful for rare diseases because quite simply you won't capture those personnel in your data set. It is incredibly time consuming for useful data, and there will be a high amount of confounding factors. And as you would expect, you're trying to get people over years and years of their life, and there'll be a high withdrawal rate from participants unless you are looking at other ways, so whether incentivizing it, throwing money at the problem, just to try and keep them on side. So a cohort study will give you a relative risk. Okay, so that's the probability of an event occurring in the exposed group divided by the probability of the event occurring in the non-exposed group. So that's exposure event rate divided by control event rate. Okay, so we've got our table up again, and we've done it here for, so we've done a cohort study, we've got those who have come out as lung cancer and those who've not got lung cancer, and then we can further divide those down into those who are smokers and non-smokers. So we can see the calculation here. Now this is just a made up study as always, just to illustrate this, and this shows that there is a relative risk 25 times greater than those developing lung cancer from smokers compared to non-smokers. Okay, just hammer home the point, because I appreciate we're going through a lot quite quickly, is that between case control and cohort, look at the second to last letter. So a control will give you an odds ratio and a cohort will give you a relative risk. Okay, and that would just be a quick way, it might be a one mark question that you can just chuck in there, and that's you nipped. Randomised control trials. So this is the gold standard for research, hopefully controlling 2 or more groups, and groups are randomised into groups, treatment and control. Placebo participants don't know what they're getting, so either single blinded, and if the participants and researchers don't know, they are double blinded. You can use crossover to get both covered, so for a period of time group A gets treatment and then a group B doesn't, and then halfway through or a set period of time they switch over. This also provides a safety mechanism, thinking about the ethics behind it, certainly if one group is doing significantly better than the other. So advantages is that you can reduce the bias from it, you can blind both the participants and the researchers, and thus gives you a greater powerful statistical analysis. The main disadvantage is that it's expensive and time consuming. Okay, and there can be high risk of ethical issues. So there are cases where certain RCTs have been cut short because one of the groups was doing so badly compared to the other. So RCT will give you an absolute risk, so that's the chance or actual risk of developing a condition, with zero meaning no risk. So the absolute risk reduction or absolute risk increase is the difference between the control and the intervention. So your control group will be your baseline. So you obviously, following that, you've got your control event rate of something happening and your experimental event rate. So it's how often that event is occurring with the experimental group. So, and you could use this for different things. So you could say you're trialing a new type of statin, you want to know the rate of heart attacks following that. Okay, so you'll have a control event rate of your normal statin, the one that you're comparing it to that's on the market already, and then your experimental event rate of the new group who you're trialing a new statin on. Okay, so you see so in this example, you see a patient who's starting on a new diabetic drug. The literature states that the rate of heart attacks is reduced. Huzzah! The rate in the control group is 20%, and the rate in those in treatment is 15% over 5 years. What is the absolute risk reduction? So absolute risk reduction is control minus EER. So that's 20% minus 0.05, which equals 5%. Nice and simple. So just be very, very careful with this one, because the relative risk reduction is your CER minus your ER divided by CER. So in our case, it's 20 minus 15 divided by 20, which is 15 over 20, which is a quarter, which works out at 25%. Okay. Now, suddenly, with a bit of manipulation, you've then got a very good news article. So extra, a wonder drug reduces heart attacks by 25%, whereas actually they are a relatively small reduction in rate, so 20 to 15%, is suddenly being re-reported. And so the relative risk reduction is often what the media will pick up to try and sell an article or sell, and get people to engage with the headlines. So just be very cautious of what they're actually reporting. Again, likewise, relative risk of less than 1, so it's protective, exercise, smoking cessation, new drugs, food groups, and greater than 1, again, nuclear waste, smoking, new drug, food groups, okay, red meat. Just remember that 1 is no difference. So RCT will give you a numbers needed to treat, and likewise, it will give you a number needed to harm as well, okay, and that's NNT or NNH, depending on what it is, okay. So it's 1 over the ARR, which is 1 divided by CER minus ER. So back to our example of the 5%, and so the numbers needed to treat is 1 over 0.05, which works out as 20. Okay, so assuming this treatment is correct, I would need to, as the GP, issue this medication to 20 people to prevent 1 heart attack, and that's what the number needed to treat falls out as. And likewise, if we knew the event rate of an adverse reaction, say death, okay, we could work out the number needed to harm in a similar way. So for example, it will give me a figure, say that if I treated 100 people with this medication, 1 person may die. So just remember that data can be used in both the positive and the negative way. And what's useful is that often this data is presented. Red Whale, which I try and get onto most years, is an excellent resource. And what I love about it is that it will give you the numbers needed to treat and numbers needed to harm. So a statin normally sits around a number needed to treat of 50 from the data that I've seen. I know it varies, and please comment below with a link if you've seen any different data. And what that means is that I work on that you need to give 50 patients a statin, you will prevent 1 heart attack. And what is interesting, and thank you to Red Whale for this one, is that the intranasal balloon devices for recurrent otitis media or otitis media with effusion, to reduce that having a chronic effect, and for the use of the balloons, as you can see the child using, has a number needed to treat of 6. And now that is phenomenal data. And actually one of those that where I can say that the statistical analysis has really supported my practice, so that when I see patients who child has got recurrent otitis media, apart from giving the normal advice, say, right, get on this nasal balloon device, we will stop it from developing any further, then requiring grommets, okay, and it can self-medicate and prevent a referral to hospital. Absolutely brilliant stuff. We can use the numbers needed to treat and harm also to interpret a Cate's plot as well. Okay, and that's where we start to pull out some of our data. So systematic reviews. Okay, so we're taking a large number of cases and we're looking at them individually. And so we're getting all the RCTs in a similar way, and we're just trying to get the whole data set together. So advantages, it's limited bias, it's focused question, and it's easily repeated, and it generally gives us very good, robust evidence. Multiple studies compared, new research can be generated. It gives good quality data, and it should reduce the time being put into practice. So thank you very much. Disadvantages of publication bias, which we'll talk about a bit later and how we can find that. Someone can select the studies and deliberately unselect them, and studies may not be directly comparable. And regardless of all our best efforts, bias can and will still persist. So just remind ourselves from video 1, looking at our box and whisker plot, and this sort of looking at our data set that's presented. Okay, so we'll take all of these from each RCT and put them into a lovely Forrest plot. Now, along the left-hand axis, you can see just the representation of the studies, okay, and the dates they were presented, and the odds ratio presented. Now, we already know that the 1 is no effect line, and so we can then transpose that any study that's touching the line basically will not give us an effect. Okay, so if they're touching the no effect line, I don't care about them. So basically, the top 3 ones we can rule out. This is a brilliant exam question because they'll often just put this Forrest plot up and say, right, which studies show no effect? And so we can say straight away, easy, top 3 don't care about. So the actual rest of the questions are going to be with regards to the bottom 2 studies below. Okay, and you can see that the odds ratio, as they hovering around the 2.2 line, those 2 studies give us the greatest effect. Okay, the larger the box as well, the greater the power, the greater the significance of the study, so it's something just to bear in mind as well. Talked about publication bias, so Forrest plots, that will basically give us every publication will give us a variation in the risks or the actual outcome. Okay, that variation will just randomly spread out. Because of that randomization of spreading, when multiple publications are looked at and plotted, we would expect that to be randomly distributed in almost, if you can, with the eye of faith, almost looking like a normal distribution. So if we look at the top one, you can see that it's not symmetrical. Okay, so that would suggest to me that the authors are deliberately picking publications that pushes a point. Okay, so they are deliberately not looking at the whole data. Now, taking a step back, there may be a good reason why that data is not out there, that the research hasn't been published, or not being looked at, or not being included. So there are multiple reasons for it. Whereas the plot below, on the bottom of shows that there is a clear spread of data amongst it, and that shows that we've got all the publications there. But just a simple one, funnel plot, publication bias, boom, should be symmetrical. If it's not, there's a bias there. Similarly, l'Able plot, I apologise for anyone speaking French if I got that wrong. Please put a comment below if you can correct me on this. And so again, we've got an equality line. Treatment better than control is above the line, and then control better than treatment below. Likewise, we get a series of circles. Okay, again, the larger the circles, the greater power that study has. So let's put all of this, all the information we got, again, back into clinical practice. Now, low carbohydrate diets to combat diabetes has had a lot of press attention. And it's got a lot of attention from the Daily Mail. Now, as GP, I automatically flinch as soon as something is published in the Daily Mail, but that is my prejudice, and we need to actually have a clear head about this. So, I was speaking as well to a colleague. He was very keen on low carbohydrate diets to combat diabetes, and wanted me, he'd had a couple of cases that he had done sort of off his own bat just to have and managed to either significantly control the diabetes or even reverse it. Brilliant. So I thought, right, okay. I was aware of a series of cases that have been published, but we need to do some more research. Now, this is where the wonderful world of being a GP is that you're presented with multiple guidelines and people telling you what to do. That's all very well of them telling you what to do, but we need to take what we've learned, certainly in this presentation, and apply it to the guidelines that are presented to us. Because it's interesting that actually some of them, even though they are guiding us, are not always based on the best evidence available. And again, that's because there's a time factor. So, these guidelines may be multiple years old and there may be new research published and they just haven't caught up. Or again, similar to any sort of bias, they've just not chosen to look at that data for whatever reason. So, first one. This one, National Obesity Forum, eat fat, cut carbs, avoid snacking to reverse diabetes. And one of their points that they put out is they say limit starchy and refined carbohydrates to prevent and reverse type 2 diabetes. And one of the main studies that they draw upon is this dietary carbohydrate restriction as the first approach in diabetes management, critical review and evidence base. Now, looking through this, they've pulled multiple data from multiple sources, and I would argue in terms of evidence, it's probably up there. Maybe not quite a systematic review, but it's not bloody well far off. Sign. So, Scottish guidelines were quite damning of the low carbohydrate diets. They report that there are high dropout rates and poor compliance with carbohydrate and energy restricted diets in trial settings, which suggest that such diets are not widely applicable or accepted to patients. And they quote 2 studies here, and I've just pulled out the bits there. Short term, 6 months, low carbohydrate as little as 50 grams per day or 110 grams per day appears safe in type 2 diabetes, whether treated by diet, tablets, or insulin, or a combination. Patients who adhere to a low carbohydrate diet, a reduction in insulin and or oral hypoglycemic agents is likely to be necessary. Okay, so, and they quote a randomized control trial, and then the other one is having a look at it, I couldn't quite suss out. It's probably a cohort study, if I'm being, to hazard a guess. But regardless, we know that we've got an RCT. We know that's sort of second from top up here. Okay. Finally, we've got NICE, who give us quite woolly advice and basically just say provide advice in form that sort of needs to their culture and their beliefs. Fine, get it. Emphasis on a healthy, balanced eating. And so actually don't pin down in terms of whether we can reduce carbohydrates safely. Okay, fine. So actually, in terms of level of evidence, because they haven't really answered our question, I put a big fat question mark on it. So looking back at this and actually diving into the papers even more, because thankfully they were certainly Feynman's paper was open source, so we could have a good look at it. It goes into a lot more detail, and you can clearly see that it's a well-researched article. And yes, actually, the Feynman's paper takes on some of the points that that Daly raises in terms of how you would regulate your carbohydrates. So whether you go down to the ultra low, down to almost less than 50 grams, all the way up to. And actually, looking at the data, as we've sort of demonstrated here, has the Daily Mail got it right? Well, actually, yes, it has. And I have now used this in multiple cases in my practice, developed a patient handout saying, look, if you are either pre-diabetic or got diabetes established and you want to reduce your medication burden, you can do this with diet as a significant contribution to it. And you can see here in small writing, Dr. David Unwin, he has done a massive amount of data to prove this. Him and his wife got a practice up in the Northwest, I do believe. His wife is a psychologist, and so between the two of them, they are reducing their diabetic medication burden tremendously. Please, if you comment below, I'm passionate about this, and I'm more than happy to do a video if you think it would be useful for your future learning. So, in summary, what's the best? You know what the best is. Systematic reviews and meta-analysis, followed by randomised control trial, cohort studies, case control studies, case series, and case studies. And finally, expert opinions and editorials. Hope you found that useful. Thoroughly enjoyed doing it. Please comment below if you'd like to see more like this. Many thanks.